Hi everybody and welcome to Chapter 12. Chapter 12 focuses on schizophrenia and other psychotic disorders. So let's start first by defining schizophrenia. Schizophrenia is a debilitating psychotic disorder that results in unbalanced or imbalanced thinking, imbalanced perceptions, emotions, and behavior. It's often characterized by things like disorganized speech, so people will just sort of ramble and say a lot of incoherent, nonsensical things very quickly. Hallucinations and delusions are all characteristic of this mental illness. So what constitutes psychotic behavior? In order for somebody to be suffering from psychosis, they have to experience both delusions and hallucinations. Those delusions can be visual, they can be auditory, but the point being that they see and hear things that are not there, and it results in a break from reality. Because they're hearing and seeing things that are not there, they can't distinguish between what's real and what's not. Psychosis is central to the diagnosis of schizophrenia. Now, in order to diagnose schizophrenia, there has to be a presence of symptomology, and there are different kinds of symptoms with schizophrenia. There's positive, negative, and disorganized symptoms of schizophrenia. First, our positive symptoms. These are the very obvious, very expressive signs of psychosis involving delusions and hallucinations. So let's talk about delusions in more detail. Symptoms of psychosis. A delusion is a symptom of psychosis that results in disordered thoughts, strong beliefs that misrepresent reality. So for example, a person will legitimately believe he or she is God, or that he or she is the second coming of Jesus Christ, and they absolutely believe it. Or that I am the only person that can bring about world peace, and it's a true belief. It's not something they're just saying, they absolutely believe it, and they behave accordingly. There are also delusions of persecution. This is when somebody has delusions that people are looking to harm them. And it's not just one person, it's usually multiple people for all sorts of nonsensical reasons. But they believe somebody's trying to get me, somebody's out to get me. They also can believe that people they know have been replaced by a body double. That's another delusion of persecution. So they might go home and say to their husband, you're not my husband, even though it's absolutely my husband. You say, I know who you are, you're here to come and get me, you're here to hurt me, what have you done with my husband, kind of thing. And so they believe in delusions of persecution where people have been replaced. They also may have delusions of persecution where they believe that they are already dead and that they are functioning in the afterlife, that they don't actually exist. Delusions may be the result of neurological malfunction, that something's just not firing correctly in the brain, or they may occur as a method of dealing with extreme anxiety and stress. The individual experiencing the schizophrenia has that excessive stress and anxiety. They have the disordered thoughts, the imbalanced speech, and they're trying to make sense of all of it, so they come up with a narrative or an explanation as to how to put it all together, to make sense of the nonsensical, unbalanced thoughts. Those are the two theories on what the delusions are, what purpose they serve. The next positive symptom is hallucinations. This is when somebody experiences sensory input that simply doesn't exist. And what that means is they see things that aren't there, or they hear things that are not there. This can be, I think we say this, but we don't really give it enough credence for the weight that it should carry. We cognitively understand somebody seeing things and hearing things that aren't there, but think about that in your everyday life for a minute, that you cannot distinguish between a person that's right here that's real and tangible and a person that's right here that you are hallucinating. You literally can't tell the difference. So everywhere you go, you don't know, especially if once you become self-aware of your hallucinations, you don't know if what you're seeing and hearing is actually happening. Imagine trying to make decisions and function on a daily basis, determining, are you real, is this not real, I don't know, I can't tell, right? So they're really very debilitating. Right. Next are negative symptoms, and these are the symptoms that are less expressive. So hallucinations and delusions are very expressive because you'll see people talking to no one, right? Or they'll say, do you hear that? Do you hear that person talking? Or they keep saying something, and you see it as very expressive. But negative symptoms are less expressive. Okay, so symptoms with schizophrenia that are negative include things like flat affect, and what that means is people who have no facial expression, no emotional reaction. So if there is a reason for an emotional reaction, they will have none. So if there's something funny happening, they will have no response. If there's something scary happening, they will have no response. It's just that flat affect of no emotional response or facial expressions. Excuse me. Negative symptoms also result in limited thought and speech and social and emotional withdrawal. Only 25% of schizophrenics display negative symptomology, so the positive symptomology is much more prevalent. There are other negative symptoms, and we're just going to run through each one. The first one is avolition. This is the inability to persist or engage in an activity, and a lack of interest and participation in daily activities. Alogia are speech deficiencies found in schizophrenia, where you will speak to them, ask them a question, and there's just no response. Or they give a response, but it's an exceptionally delayed response. So literally 4 or 5 minutes might go by, and a question you asked 5 minutes ago that you assume they're no longer addressing, they'll come forth with an answer. This is theorized that the reason people suffer from alogia is because they have trouble accessing the right words to respond because of that imbalanced thinking. There's also anhedonia, which is schizophrenics demonstrate an inability to express interest in things that result in pleasure that we all take part in, or that everybody would like to take part in because they're pleasureful. So for example, things like eating or having sexual relationship, those are all things that bring pleasure, but they don't bring any pleasure to a schizophrenic. They have no interest. Asociality is just simply a lack of of interest in social engagement with others. If you think about a lot of their positive and negative symptoms, that should make sense. That if they have a hard time getting words to express themselves verbally, it might be easier to just not engage. If they are having hallucinations and delusions, people often have negative feedback or negative uncomfortable reactions around them when they're having those delusions. So it might just be easier for them to just isolate and be asocial. Affective flattening is a lack of emotional reaction physically and verbally. However, we don't know, they may be having the emotional reaction internally. Doesn't mean they're not having it at all, but they're not physically expressing it. And this is often characterized by a vacant, empty stare. Just, it's almost like they appear as though there's nothing in there. But we don't know, there may actually be an emotional reaction going on. Disorganized symptoms is the next category. And these are erratic behaviors that affect speech, motor skills, and emotional reactions. So the first is disorganized speech. This is illogical speech that often jumps from one topic to another topic. It won't have any order. It won't make sense contextually. It's just random words coming out. There's also inappropriate affect. And inappropriate affect is one of the more, I think, disturbing symptoms of schizophrenia. And inappropriate affect is when you have an emotional reaction, a powerful emotional reaction that is not appropriate to the situation. So, for example, you may have learned that someone just died, and somebody who has inappropriate affect might start laughing hysterically and gleefully and joyfully for an extended period of time. That's not an appropriate emotional response. Things of that nature. Okay, so, or they might cry uncontrollably at a situation where there is no trigger or reason for somebody to cry. Catatonic immobility is also interesting. This is when schizophrenics can hold unusual postures for extended periods of time. So they might stand on one leg for 7 hours with their arm raised, right? And they literally will not move for that 7 or 8 hours, because the concept that they have in their mind is that if I move my posture, if I change this posture, something bad is going to happen, so I have to hold this posture. And they will. They will hold that posture for hours upon hours upon hours. They can also experience something that we call waxy mobility, which is really interesting. So that, let's stick with that example. You're standing on one leg with your arm raised in the air. They've been like this for 4 hours. And if somebody were to go up and they had their arm raised and say, put their arm like this, they'll hold it like that for the next 4 or 5 hours. And we call that waxy mobility. Waxy is though we can shape them physically. It's mobile. We could shape them sort of like a Gumby, right? This is something that happens with catatonic immobility. I want to talk about the schizophrenia spectrum and other psychotic disorders. The DSM used to categorize schizophrenia in 4 or 5 different specific categories, and now it is defined as more of a spectrum, and it also distinguishes for other disorders of psychosis. The first is schizophreniform disorder, people who demonstrate symptoms of schizophrenia for a limited period of time, and when I say a limited period of time, we're talking a few months, where all of a sudden the symptoms disappear. We identify them as having schizophreniform disorder. Whether the symptoms disappear because they receive medication or treatment and the symptoms just disappear completely, or if they receive no treatment and all of a sudden there's just an absence of symptomology for no apparent reason, we identify that as schizophreniform disorder. And there's no clear reason why this occurs. There's no clear understanding as to why the symptoms simply just randomly go. Next is schizoaffective disorder. Schizoaffective disorder is a psychotic episode that demonstrates symptoms of both schizophrenia and a mood disorder. So the mood disorder must be present, whether it's depression or it's bipolar or it's mania. One of those needs to be present, but also in conjunction with delusions and hallucinations in order for it to be considered schizoaffective disorder. Delusional disorder is the persistent experience of delusions in the absence of other schizophrenic symptoms. So the individual may experience very real delusions, but they're not experiencing anything else, right? They're not having any of the other negative or disorganized symptoms. They may be convinced that my neighbor is spying on me, and with the ultimate plan to kidnap me and sell me for organ harvest. It'll be something really off the wall, something really wild and crazy that doesn't make any sense, and there's no clear reason why the individual thinks that, but they focus and perseverate on their delusions. They will not experience hallucinations, flat affect, catatonic immobility, or anything else. Next is shared psychotic disorder. It also is known by a French phrase that is called folie à deux. Folie à deux, or shared psychotic disorder, is exactly what it sounds like. This occurs when an individual develops a delusion that is identical to another's delusion of another individual that they're close to. So whether it's a friend or it's a coworker, it's a spouse or whatever, the delusion starts with the other person, and all of a sudden it's almost sort of like it hops, it's shared, it's contagious to a second person, and now they're both sharing the delusion. It's not real for either one of them, but they both believe it to be real 100%, and they share the delusion. It's often also referred to as shared psychosis. Next is attenuated psychosis syndrome. The onset or experience of psychotic symptoms. This is seen as a precursor to developing full-blown schizophrenia. So it's the beginning of your psychotic symptoms. It's the beginning of delusions and hallucinations. The other symptomology hasn't yet set in, so there's not yet flat affect or disorganized speech or catatonic immobility, but you are suffering from delusions and hallucinations, and we often see this as a precursor to full-blown schizophrenia, that it's usually when we see attenuated psychosis syndrome, it's just a matter of time before full-blown schizophrenia develops and is diagnosed. Something that we should know about schizophrenic disorders and psychosis of all kinds, very, very strong genetic component to this, incredibly strong genetic component to this. And all of this is sort of taking place in the brain, and it's very tangible mental illness. So for example, what I want to say is that there's no one schizophrenia gene. It's a series of genes that somebody's born with that come together and sort of activate when the illness happens. You can simply be a carrier, right? You can be somebody who has all those genes, but they may never activate, right? No one gene can do this. It's a series of genes. We see that schizophrenia runs very strongly in families. We see it run very, very strongly in identical twins. We see it run very, very strongly in the offspring of identical twins, which tells us this is a very powerfully genetic driven disorder. So for example, just to give you some numbers, in the general population where there's no familial attachment to anybody else with schizophrenia, we are all at a 1% likelihood of developing schizophrenia, which is incredibly low, highly unlikely. However, when we look at adoption studies, so we have separated the genetic parents and the genetic offspring, right? So there's no environmental influences. The genetic adopted child is raised in a completely different environment, but if their parent had schizophrenia, they have a 25% chance of developing it in their lifetime, which is obviously a huge increase from what the rest of us have. So there is most definitely a genetic predisposition to this. But like I said, you can be a carrier. It's not guaranteed. It's not genetic destiny. If you have a 25% chance, that means you also have a 75% chance of those genes not activating. Okay, let's talk about treatment. So early treatment of schizophrenia was fairly unsuccessful, as most illnesses, mental illnesses. And we went to sort of the usual suspects, using electroconvulsive therapy, insulin therapy, and unfortunately frontal lobotomies, which were just useless all around, very destructive. And all of these things that are very intense and very invasive, failed to adequately treat schizophrenia. So we have come a long way, and one of the big improvements that we have developed are something called antipsychotics, which are pharmacological medications that are specifically going to treat the delusions and the hallucinations, which must be a huge relief, right? That once those are under control, you can get a grip on reality again. You don't have to start wondering if everything's real or if everything's fake or if everyone is out to get you. There are two sort of waves of antipsychotics. Pharmacists came out with the first wave and saw success, and then the second wave was developed, and we see even greater success in treatment with the second wave of antipsychotics. However, both waves come with some really unpleasant side effects, and those side effects can be pretty intense. So extreme lethargy and grogginess, extreme fatigue, to the point that you're unable to function. So great, you're not having delusions and hallucinations anymore, but now you can't get out of bed and you can't keep your eyes open. Yes, it's good that you're not having this, the positive symptoms, but if you can't function, really, is that really helping you? So what ends up happening with antipsychotic medication is there's a lot of non-compliance. People don't like the side effects, and so they simply stop taking the medication. So things like I said, so blurred vision is another one, very blurry vision, you can't see, you're groggy, excessive dry mouth, interruption of proper motor function. So your motor skills are off, you can't move properly when you take antipsychotics. Often results in things like hand tremors, involuntary movements of the tongue, the facial muscles, the jaw, right? So great that you're not having these symptoms anymore, but you're having all of these really, really uncomfortable side effects that are very noticeable to the people around you. So non-compliance becomes a really big issue. Like I said, the side effects make people not want to take it. Embarrassment, negative relationship with the doctor. Often that there will become a lot of disagreement. The doctor will be very much like, you need this, you need this, you need this, and the person who needs the treatment will say, okay, but I don't want my jaw flopping about, and you've never had the experience of you're trying to talk to somebody and you have involuntary movement of your tongue, doctor, so don't tell me what to take. Right? And the doctor's like, okay, that sucks, but you need it. No. And there becomes a break between the doctor and the patient because the doctor isn't being empathetic enough or understanding enough about how very difficult the side effects actually are. We've also seen improvement of behavior with something called token economies. And token economies are something that are done within formal institutionalized treatment. So this isn't for people living out in the world. This is for people who are in a formal mental institution. And what it is it's a behavior modification system that is utilized in an inpatient setting where you are given, the schizophrenic patients are given rewards or tokens when they minimize the unpleasant behaviors and start displaying more pro-social behaviors. So, for example, the tokens or the prize would be snacks, extra, recreational time, more access to TV or something like that. So things that are essentially what this is, it's a system of positive reinforcement. That when you engage in good behavior, we give you a reward. You like the rewards that we give you, so you want more of them, so that increases your good behavior. And it forces them to really, really focus on their symptoms and try and get a hold of them, because there's a direct, immediate incentive to do so, a direct reward in order to do that. And that is our chapter on schizophrenia.